to another live session with the virtual tutor by MedSync. Today we're going to be talking about accessing the structures of the hand, the different incisions, and common places to find common places to find the structures in the hand once they're cut, like the tendons and when they retract, and how you decide which techniques to use. So we're going to start with incisions for the hand. There are two really common incisions for the fingers and two for the palm. The first thing is to note where your creases are. So this will be the MCPJ, this is the PIPJ, this is the DIPJ, metacarpophalangeal joint, proximal interphalangeal joint, distal interphalangeal joint. You've got the distal palmar crease, I don't know if you can see that in my hand, just running about here and somewhere like here, about here. So you want to factor these things when you're making your incisions. So how do we access the structures here at the A1 pulley? This is typically something you need to access for a trigger finger release and the finger's getting caught, or for a flexor sheath washout where you need to access A1 and A5. There are two options. The first is a chevron incision. So you want to note where your metacarpal head is, which is not distally at the MCPJ, it's proximal to that because that's the joint between the metacarpal and the phalanx. Just proximal to that, you can feel the head if you bimanually or palpate on both sides, and so that's there. So I want to access around the metacarpal head, which is where the A1 pulley is. You can either do a chevron, like so, or you can simply do a transverse incision. What are the benefits of this? A chevron incision gives you good access. You can visualize your nerve and artery. The question is which one is on top at this level and which one's on top at this level. We'll come to that. And you can retract them out of the way and you can see the A1 pulley very clearly to get into it, to cut it, and know that you haven't damaged the nerve or the artery. But if you're just beelining for your structures and you know that your nerve and artery sit here, you can also just do a transverse incision if you're not needing to look for them. So, to answer the question of which one sits more volar, in the palm, the artery sits on top, or volar, or palmar, to the nerve, and then as it enters the finger, the nerve sits more volar or palmar to the artery. So, chevron incision. You make your skin incision here. I'm actually going to do it. You'll get the fat. The nerve and artery might be the common digital nerve or the common digital artery, and it might be branching off. For the index finger, it's going to have its own nerve coming off, and then the common will come off here, and you'll see it splitting into two. You'll see one splitting into two. You'll see one splitting into two, and then the corner border will have its own. So let's do those incisions on my third hand. So we said chevron, so like this. So you're going to use a knife, and you're just going to make your cut. I'm going to use scissors for simulation. That's a broad incision through skin. It's very difficult to get retraction in there, so what you can do is place a stay stitch. So it's learning how to operate without an assistant because you don't always have one. So just take the tip and you just place the suture in an area out of your way. I think with a chevron incision, the idea is that you want to see your structures. So you want to tack that out of the way, and then you don't need an assistant to retract for you. cut the sutures long because you're going to take them out at the end. So it's just a stay stitch for yourself. As always, when you want to use a suture again but you want to secure it, turn the pointy bit into the needle holder and face the body. So we're discussing accessing the finger. This was the chevron incision, just like this. Over the A1 pulley, you'd have fat, artery and nerve. You can simply retract them out of the way and get straight down to the pulley. That's a chevron incision. Then you've also got the transverse incision. You palpate the metacarpal head, not the MCPJ, the head. You make a transverse incision just there. Now for this, you may need someone to retract out of the way because you're not going to have this broad access. You typically will be doing an incision like this when you want to do a flexor sheath washout. So the A1 pulley is here. You need to do an incision over the A5 pulley, which is typically just a transverse incision over the distal interphalangeal joint. We will discuss in a second the different pulleys. So you use a knife. Now, in my experience, what you need to be careful of here is the nerve and the artery, because at this level, the nerves and arteries start to trifurcate and split into their different branches, but they can be a bit more anterior than you expect. So you make your incision through epidermis and dermis. You might see a vein or two. I recommend spreading along the axis of your structures, so not this way because you might cut them. Spread in parallel to them. You open, and then you can retract whatever structures out of the way to get to the A5 pulley. You then want to put a cannula or a blunt needle under the flexor tendons. You've made a hole in the A5 pulley, a hole in the A1 pulley, and you can flush clear fluid out to wash out the pus in the flexor sheath. Now, the issue you can sometimes have is that the pus is not just in the flexor sheath, it's throughout the subcutaneous tissue. So you need to open the whole finger. So how can I best do that? So this incision lends itself to a few options. You've got the Brunner incision and the mid-axial. To do a Brunner or mid-axial, you need to mark the end of your joint creases. So if you flex the finger, mark the end of the creases on both sides. Regardless of which one you do, you need to go to the end of this point. So let's say I want to do a Brunner incision. Mark all these up. Because I've got a chevron already starting here, I'm going to continue that. And then I'm going to go all the way across from there to there, all the way to the end of the joint crease. It's really important that you don't stop before, because then the scar contracture will limit function afterwards. And then I need to get to here. So let's do that on this hand. So we've gotten to here. I need to get to here. I need to get to here. So let's join those up. And this allows you to open up the entire finger, and the indication would be that there's pus in the flexor sheath and in the subcutaneous tissue. You'd be using a knife. You will come across veins. You know where you can cut because you should know where your nerves and arteries are. But fortunately, if you don't, I'm going to tell you where they are. Let me just finish opening this incision. This is a Brunner incision. There's variants of this which we will also discuss. It's called a hemi-Brunner, and the indication for this is very specific. Now, what you need to be careful of is this is a very narrow flap. If I zoom in, the angle from the distance from here to here is very, very narrow. So I might want to increase that angle a little bit. So I might come out all the way to here actually, just to increase the flap viability all the way up to there, and then connect that. Again, you'd be doing this with a knife. It'll be a bit adherent, so you can dissect, 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 and wash out all your subcutaneous tissues. The good thing about Brunners is that when you lay the skin flaps back down, they are at low risk of causing contractures of the finger. If you do a straight incision through the finger, you have to do Z-plasties to increase the length of the scar so that the finger can extend and flex to its full length. So the Brunner reduces that risk, but there is the risk of skin tip necrosis, which is why you have to make sure you have nice broad-based flaps. The context in which we're doing this is the washout of a flexor sheath. You've opened A1, A5, there's pus inside there, but there's pus all throughout the subcutaneous tissue on top, so I've had to open the whole finger. So I've marked the end of the joint creases on all sides. I'd already done the chevron incision, so I just connected all the dots and opened it. So that's the Brunner incision. The other incision I mentioned is the mid-axial. It's like a book. So the way this works is at the end of the joint crease, you're going to make an incision like this. Now, you could do the incision from here all the way down to here, and then come to here and make it a chevron type thing, like so. But rather than run the whole incision longitudinally, in an uninjured finger, it might be better to alternate your book flap. So what I'm going to do is mark this crease. I'm going to go to here. I'm going to make an incision there. I'm going to go from there to there. I'm going to go from there to there. And I would have already had the incision at A5 from there to there. This will open like this. This will open like this. So let's do that. So let's transpose that onto here. So we're here, 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 here. Here, 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 here. We have gone up to there, the end of the joint crease, over to here, and we've already made this A5 incision. So it's like books. This is in an uninjured finger. The key principles being they're nice broad flaps. I already have the transverse incision here. The nice broad flaps that reduce the risk of vascular compromise of the skin. You ideally wouldn't have. You need to think about how you plan your incisions if you're opening two fingers, but for now, let's just work on the different incisions. Again, you'd be using a knife, and we need to talk about where you find your neurovascular bundles, but we'll do that on the next section. We talk about the variants and injured fingers. So it opens like a book. Same thing on this side. Again, you'd use a knife, but this is a simulated model, so this is called the mid-axial incision. So it opens like a book. This would go down here, this would go down here, like so. So we've covered the Brunner incision and the mid-axial incisions. Both of them you alternate the side the flap is raised. Now, where things get a bit more challenging is when you already have a cut in the finger. So let's talk about that. So let's say you already have a cut down here. Patient was peeling an avocado and has slipped and gone into their finger. When you assess their sensation or their feeling compared to a normal finger, so this is normal, this is normal, this is abnormal, feels woolly, this is normal. You think it's an isolated injury to this side of the finger. In the finger, the nerve sits anterior or volar or palmar to the artery. It sits just anterior or palmar to the it sits just anterior to that mid-axillary line. So if I think my nerve is only cut on that side, I'm not worried about this side. I'm not going to go looking on this side. So I can probably just proceed under local anesthetic, provided the tendons are intact. So FDS inserts here, FDP inserts here. Flexor digitorum superficialis, flexor digitorum profundus. FDS flexes the PIPJ, FDP flexes the DIPJ. You ask the patient to hold their fingers down, hold those fingers down, flex their finger, and then flex the tip. They should be able to bend just the tip. If I'm concerned about tendons, I won't do that. I won't just be exploring that side, I'll explore the whole thing. So I'll do a proper incision, either a Brunner or mid-axial. But if I'm just concerned about an isolated injury to the nerve on this side, I will just open this side. The issue with the nerve injuries on this side, though, on either side, is that if you injured the nerve, you may have injured the artery. So you want to make sure you can get full access. It seems a bit extreme, potentially, to do a full Brunner or a full mid-axial. It's reasonable if you do, but you don't necessarily have to. So another alternative is a hemi-Brunner incision. And the way you can do that, if you mark, and you mark, if you think it's just going to be here, nerve and artery, what you can do is simply go to this point. Maybe angle it like that. So rather than crossing the whole hand, you can just open a skin flap here. So that's what we're going to do over here. So our cut was here. We've marked our creases, So an isolated injury to the nerve and the artery, I don't think it's going to have retracted because you've got the Grayson and the Cleland ligament. Cleland ligament being on the dorsal side, Grayson ligament being on the volar side. They hold the neurovascular bundles to the bone. So I'm just going to raise a skin flap, a hemi-Brunner, on one side to explore just one part of one neurovascular bundle. Just in there. And you can see your structures. You know that they'll just be lying right here underneath the fat, and access things here. Some have concerns that if you've cut the nerve and you've cut the artery, you're basing a skin flap on potentially a vessel that may be cut. So you may prefer to do something else, and that is my preference. I would just do a single mid-lateral incision, but I would base it on the other side. So let me show you what I would do. So if the cut is here and the sensory problem is on this side, I want my flap to be based on this side. So I want to cut down this side and raise it off this side. So my crease is here, up to here, and up to here, and the PIPJ is here. So I'm going to do a skin flap whose blood supply is maintained on this side. Similarly, if you do a Brunner, you can do the same thing. Well, let's say that cut was over here. If you're concerned about the blood supply on that side, you can simply base a flap on the other side. And then, as you can see, you maintain the blood supply over here. You can access the neurovascular bundle over there. You simply put a stay stitch on this bit, and you can also explore that side if you're concerned. You can explore the FDS as well. In reality, the hand has a really good blood supply, volar, dorsal, and on the other side of the finger, so this skin flap should survive regardless. So we've talked about the different incisions. We've talked about an isolated chevron incision. We've talked about a Brunner incision. We've talked about the mid-axial incision. The key to these is that the flap goes all the way to the end of the joint crease. It doesn't stop before, otherwise the scar will cause a small contracture. If you have an incision that runs down the middle, which we do in Dupuytren's, it's called a modified skook, we do that on purpose. You will need to put a Z-plasty through it, because otherwise you'll get a nasty contracture that might limit function. So if you make longitudinal incisions, don't need a Z-plasty in between. A Brunner avoids that, a mid-lateral avoids it. You have to pick your incisions and dissection based on where the trauma is. You can do a hemi-Brunner, you can do a mid-axial, you can do a full Brunner. But if I'm raising a skin flap from this side, ideally there's no injury or suspected injury to that side. One of the key things you need to be suspicious of is a patient that has numbness from a cut somewhere here on both sides of the finger. So the patient's numb here, the patient's got a cut here, but they're numb here and here. If the patient has a numb finger on both sides, you need to be suspicious that they've cut the vessel on both sides. Does it change your access? Not really, but it means you need to be prepared for potentially some microsurgery, which we'll be coming to in some of our live sessions in the new year. We talked about the pulleys for flexor sheath washouts. You've got the A1 pulley, the A5 pulley. A1 pulley is around the metacarpal head, not this crease at the metacarpal head. The A5 pulley is at the distal interphalangeal joint. A1, A3, A5. So the A1 is around, goes up to this level of the first joint crease. You've got A3, and then you've got A5 at the DIPJ. So either way to remember it is A1, this crease, A3 at the PIPJ, and A5 at the DIPJ. A2 and A4 are in between. So A1, A3, A5, A2, A4. The A stands for annular pulleys. Again, A1, A2, A3, A4, A5. When you're doing flexor tendon repairs, one of the kind of key questions people will ask you and things you need to think about when you're doing these repairs is the pulleys you need to maintain are A2 and A4. If you vent all the pulleys and the whole flexor sheath by opening them all, you will get bowstringing of the tendon and flexion will be limited. So if you're going to dissect through the structures to get your tendon from here to here, the two pulleys you need to keep would be A2 and A4. You can keep one or the other, worst case scenario, but ideally A2 and A4 to prevent bowstringing and enable good function of your repair. We talked about the position of the nerve and the artery. In the finger, the nerve is anterior or volar to the artery. It sits just in front of the mid-axial line. The mid-axial line is marked by marking the creases of the joint, and the nerve and artery will be sitting right there. If you want to have an idea of where your nerves will be, when you make that incision, you'll see these round little white bubbles amongst the fat. They're called Pacinian corpuscles. They're proprioceptive, and that usually means there's a nerve in the vicinity. So then you proceed with caution. When you dissect around nerves and vessels, this is my biggest tip for you tonight. Dissect in parallel to the structure, not perpendicular. So that way when you open your scissor, you stretch along the structure, you're less likely to transect it and cause injury that you have to repair. Talked about the hemi-Brunner. Now, the last thing to talk about is where structures tend to retract to, in particular, tendons. So the two tendons of the flexor side are the flexor digitorum superficialis and the flexor digitorum profundus. At the level of A1, the FDS splits into two, and the FDP runs in the middle. FDS will run up the finger and insert onto the middle phalanx, and the FDP will continue and insert to the distal phalanx. So at the level of the middle phalanx, you may have to do a repair anywhere between here and here. You have to do a repair of two separate slips, whereas the FDP will be one. But positionally, the FDP comes through the middle of two slips of FDS. This happens at campus chiasm, which is at the level of the A1 pulley. The issue with tendon injuries is that they can retract back to where they came from. So if I cut the FDP or one of my slips of FDS, it can retract back to where it came from. The muscles of the forearm give rise to the flexor tendons in the fingers. They come from the common flexor origin, which is at the medial epicondyle of the elbow. But there are key points that stop them from retracting all the way. But if they do retract, I'll tell you where you can find them. The vincula are blood vessels that supply the tendon sheath. There's long and there's short vincula, and if you cut your tendon, if the vincula is intact, you will find that it may stop it from retracting all the way back down. That's the first barrier to the tendon going back towards the carpal tunnel. The second barrier is the pulley itself. So you open this cut here, and you can't see the tendon. Rather than opening the whole finger, you open at the A1 pulley. Either a chevron or a transverse incision. I prefer to use a chevron because it's trauma. I need to retrieve it if it's there. So I would do this component of the incision just here and see if I can find it inside the A1 pulley. So make the chevron incision through the skin, retract the nerve and the artery and the nerve, because it'll be that way around. Incise the A1 pulley transversely, or you can cut half of it, a leaf of it. If the pulley sits like this, I might just cut, let me show you, I might just cut here, and here, to see and retract that out of the way. I haven't cut the whole pulley, I've just vented some of it, so the other half of it's still there. See if I can find the tendon at this level. Usually there'll be a hematoma that comes out, and I'll see if I can retrieve it through there. If I can retrieve it through there, I need to tunnel it underneath the pulleys to get it to the site of the cut to do the repair. If it's not at the A1, if it's not at the zone of the injury because the vincula holding it in place, and it's not at the A1 pulley, the next place you need to go to is the carpal tunnel. To mark a carpal tunnel, it's the same as a carpal tunnel decompression. Radial border of the ring finger, Kaplan's line, palpate the hook of hamate. First web plate to the hook of hamate, like this. My incision is going to be somewhere like this. You can open the carpal tunnel. You don't need to go past the proximal wrist crease. Incise, you end the incision in the fat pad. You end this incision distal to the proximal wrist crease. Skin, fat, fascia, sometimes there's some muscle in the way. Don't deviate too only, otherwise you'll end up in Guillaume's canal. Don't deviate too radially, otherwise you'll end up in the thenar muscles. You might come across a hypertrophic palmaris brevis. Just buzz the muscle end, and then you make an incision through the transverse carpal ligament, and then the nerve should pop up. You can see your tendons underneath this. Now, at this point, if you find your tendon here, you need to get it from here to here to here. We can cover that in another session, but usually I use a pediatric feeding tube, stitch it to it, and tunnel it through. It can be quite the challenge, but that's the common sites you find your retracted tendons. At the site of the cut, held in place by a vincula, retracted to the A1 pulley, or into the carpal tunnel. So, we've talked about access to the hand. It's a very inky hand. Using a Brunner incision, which you mark the ends of the creases, a mid-axial incision, where you mark the ends of the creases, a hemi-Brunner, where you don't go all the way across, you end, and that's when you're looking at an isolated injury to one side of the finger. It can be that side or that side, and you base it on there. Things you need to think about are, where are your structures likely to be cut, and where do you want to base your blood supply? If you think your structures are cut on that side, nerve and artery, you may want to base your blood supply on the flap on this side. So that's when, if I think my nerve and artery are cut here, I'll base a flap on this side and lift it this way. The different pulleys of the finger. A1 at the level, up to the level of the PIPJ, up to the level of the MCPJ even, so around the metacarpal head to here. A3 is at the PIPJ, A5 is at the DIPJ, so it's A1, A3, A5, A2, and A4 in between. They're the annular pulleys. If you're going to open pulleys and release them to get your tendon through or do your repair, you need to keep at least A2 and A4 to stop the tendon from bowstringing, where it lifts off of the bone and you cannot exert strength through it to get flexion of the fingers. My last tip was that you should try and tack your skin flaps out of the way so you can get access, and obviously marking your incisions before you start is really useful. If you got value out of that, please like it, leave a comment, ask any questions, and most importantly, if you're a bit confused, just watch it again, put on a glove and plan the incisions on yourself. That's often what I find very helpful when I'm learning how to do things, is that you have to try it yourself, not just watch. Take care and have a good evening.